welcome to our Q&A. I've got something that I've held over from last week, which I wasn't able to answer last week because I didn't know the answer, and I went and researched it. And so I'm going to start by sharing that. And while I do it, if you've got any questions, pop them into the chat. All right, so last week Tess asked about cramps, and she asked about a client who gets muscle cramps during exercise, and I'm sure, most of you guys have either experienced it yourself or had clients that when you do exercises, things like typically shoulder bridge on the reformer or shoulder bridge maybe with your feet on a foam roller. Sometimes, people get cramps in their hamstrings in those exercises. And, there are other situations where people get cramps as well. But generally it's when the muscles are in a really shortened position. And so the question was what causes that and what can you do for it? And my answer was don't know and don't know. So I had to go and look it up, and I spent some time on Google Scholar in the week looking it up and reading all about it. And now I can say that with confidence that I still don't really know. So what I learned is that there's been a fair bit of study on cramps, but they're kind of elusive, and science doesn't really understand what causes them. So there are a few different kinds of cramps, or people get cramps in different situations. So there's pregnancy-related cramps, which seem to be more common than people who are not pregnant getting cramps. Then there are what's called idiopathic nocturnal cramps, which is just a fancy way of saying people get cramps when they're asleep and we don't know why, because idiopathic means we don't know why. And then there's a third category where people have like a pathology like diabetes or multiple sclerosis or something like that where the cramps are a direct result of their disease process. And then the fourth category, which is what we're interested in, is exercise-associated muscle cramps. So that's basically people, when they're exercising, doing shoulder bridge on the reformer, their hamstrings cramp up, or whatever other muscle when they're doing a particular exercise. And so there are competing theories as to what causes cramps. And so the original theory was proposed sometime in the 1930s, I believe, which was the electrolyte/dehydration hypothesis, which basically says that when people become dehydrated, we sweat a lot, and when you sweat out salt, and that changes the balance of electrolytes in your body. And the electrolytes, sodium and potassium and magnesium, these things are involved in the mechanism of nerve conduction and muscle contraction. And so when you change the balance of electrolytes in your system, it kind of screws with your muscles and nerves to the point where muscles start firing when they shouldn't, basically. So that's the hypothesis. And there are several lines of evidence now that is incorrect. So when we look at, for instance, people running marathons who sweat a lot and have very weird electrolyte balance or imbalance in their body towards the end of a marathon, what we find is people who have cramps in the marathon and people who don't have cramps in the marathon have the same kind of levels of electrolyte, in their blood. So that, we look at people's blood levels of sodium or potassium or magnesium, and it doesn't predict who's going to get a cramp and who's not going to get a cramp. Another one is when we actually experimentally, inject sodium or potassium or magnesium into people, it doesn't cause cramps or alleviate cramps. So, there doesn't seem to be a strong relationship, if any relationship, between those things. And also just kind of from a plausibility standpoint, if there was a systemic thing where your system is low in sodium, or overall your system is low in magnesium or whatever, well, why would that cause a local effect at one muscle but not at another muscle? If your whole system was low in magnesium, why does it just cause your hamstrings to cramp? Why doesn't it cause every muscle in your body to cramp? So so that and lo and behold, I found also a Cochrane systematic review from 2020, which is super recent and is a really high quality paper, that found that magnesium for muscle cramps doesn't really have any evidence. So it's not not an effective treatment in pregnancy-related muscle cramps, and in all of the other types of muscle cramps, it basically hasn't been studied enough. There's really poor quality or not enough evidence to say whether it does or doesn't work. But just from a plausibility standpoint, it doesn't seem that it would. So put down that magnesium. And so the next hypothesis is it's called I can't remember what it's called, but it doesn't matter what it's called. But basically, it's a neurological scenario. And there are two ideas. One is that the cramp originates in the nerves, local to the muscle, and the other one is that it originates in the spinal cord. And it looks like the spinal cord hypothesis has more evidence. So basically, what science currently thinks happens with cramps is when a muscle. So you have little organs within your muscle, little sensory organs within your muscle called muscle spindles, and they're just kind of little sensors that sense the length of the muscle. And they also sense how quickly the length is changing, right? So they can tell if the muscle's shortening or lengthening fast, and they also can tell how short or long it is at any given moment. Because when you lengthen the muscle, basically you lengthen the spindle and it gets stretched, and so that they can send that information to your nervous system. And they have a role in inhibiting muscle cramps when muscles are lengthened, right? And so when you've had a cramp, right, in a muscle, what do you do to that muscle? Stretch it out, right? You want to stretch it out to alleviate that. That's kind of instinctive, right? And so, at all times we have some level of, nerve impulse going to that muscle, telling it to turn on, right? And we've also got what's called descending inhibition, like a nerve impulse going from your spinal cord going, don't turn on, right? And so there's a sort of a balance between those signals. And when the don't turn on signal is stronger, well, it doesn't turn on. And when the turn on signal is stronger, well, it turns on. But there's always some amount of both signals going to the muscle. And these muscle spindles, when the muscle is lengthened, they increase the amount of don't turn on signal. It's called an inhibitory signal. And that is supposed to prevent cramps when the muscle is lengthened. But another way of thinking about that is it actually doesn't prevent cramps when the muscle is shortened, right? So when the muscle's in a fully shortened, contracted state, the muscle spindle doesn't fire that inhibitory signal, which prevents the muscle from cramping. Cramping is just when the muscle contracts, basically, and you can't stop it contracting. And as you fatigue, the central nervous system, wrecking your brain and spinal cord, recognizes that the muscle is fatiguing and can't produce as much force, right? So it turns up the signal to the muscle to fire more because the muscle's not producing as much force. So you sort of, turn on the gas more to get more force, right, out of this fatiguing muscle. So you get more signal going to the muscle saying turn on because of the fatigue, and then you get less signal saying turn off because the muscle's in a shortened position and the muscle spindles become inactive. And the combination of those two things means that when your muscles are in a fatigued state, a somewhat fatigued state, and fully shortened, that's when they're more likely to cramp. And so what can we do about that? The answer is, well, when you're in a fatigued state, don't fully shorten your muscles. But there's no medication, exercise, surgery, a nutritional supplement, hydration regimen. There's nothing that is known that has any meaningful effect apart from just avoiding don't do shoulder bridge on one spring when you're tired. Yeah, so sorry. I'm sorry. That's a very unsatisfactory answer and highly technical. So if any part of that doesn't make sense, or if every part of it doesn't make sense, let me know, and we can talk through it in a little bit less technical terms. So does that kind of make sense to you? Do you have any questions about that? Is that surprising to you?
It's good to know. I think it's really interesting, and sort of never know what to, when people doing hamstring curls or something, I'm cramping, why do I keep cramping? I never know what the answer to that is. And I sort of don't know that magnesium's not really a solution to it. So, yeah. But Raph, on that, what about stitches? When you're
Oh, gee, you've asked me another one I don't know the answer to now.
Pardon?
I don't know. I don't know the answer to that. What's a stitch?
That's another
I'm going to have to go look it up.
one.
That reminds me of like when my mum said when I was a kid, I don't go in swimming for half an hour after you have lunch, you know.
Exactly. Yeah, that's right. Yeah, it's quite funny.
I don't know if that's a real thing either. But
No,
does anyone else have any idea about what a stitch is and what? I mean, you know, you get it when you run a lot, or sometimes I think maybe when you eat just before you run. I don't know. Anyone have any ideas?
Wasn't there like something with a stitch that it's actually like air caught in the diaphragm somewhere?
Yeah.
So, and it's a bit of referred pain from that, like so that, you know, until you can kind of regulate your breathing a bit more and it will then kind of dissipate. But I could be wrong there. Who knows?
I'm going to look it up and probably I suspect that the answer is going to be like a really long-winded version of we don't know. Just like it was with cramps, you know. So now, Andrea, when your clients go, why am I getting a cramp? You go, oh, well, the muscle spindles are sending a decreased inhibitory stimulus to the central nervous system, and because your hamstrings are fatigued, you're getting increased, you know, descending, excitatory signals. And then because the muscles are in a fatigued state, so therefore the cramp inhibition is reduced, you know, but it's like, what does all that mean? It means like, yeah, don't really, you know, don't know. So, I don't know if that's going to be of any use to any of you in working with clients, but it is kind of interesting to know that it's to do with the fatigue of the muscles, it's to do with them being in a shortened state, and it's to do with your spinal cord basically firing off additional signals because they're in a fatigued state, you know, and trying to ramp them up to work harder because they're not working as hard because they're fatigued. Yeah. Carly says, my PE teacher in high school said it was a buildup of carbon dioxide, so breathe out harder. I don't have any opinion on that. I'm going to look it up, but I'll get back to you in a week. What causes a stitch? All right, so cramps, what do you do? Just avoid that inner range of motion, right? So you can do shoulder bridge, but it's, you know, when you do the shoulder bridge, it's the keep the carriage in on the stopper instruction. That's the one that causes people to cramp, right? If you let them push out a bit, they don't get those cramps. And the same with if you're doing like hip lifts or shoulder bridge or whatever on a foam, with your feet on a foam roller, it's when you're pulling the roller in towards your backside, that's when people tend to cramp with the hips up in the air because then the hamstrings are maximally shortened. Yeah, so just let them go through a slightly larger range of motion, and that should sort of solve the symptom, but yeah, don't know what causes it. All right, Andrea says, I've noticed that the old school exercise like upright rows, chin-ups with the bar behind the head, and pull-downs with the bar going behind the head aren't really practiced now. Is this because the scapula isn't in its correct position and the plane of those movements is causing shearing on the tendons? What injuries, if any, could performing these exercises cause? I have also noticed that those exercises, you know, like if you go and watch like old school exercise videos from the 1970s and 80s, you see everyone doing their lat pull downs with the bar behind their head there. And you never see that these days. It's kind of frowned on. And there are a bunch of and upright rows. I don't know. I see those done, but that's just basically standing and you lift up like so. I see those done. You know, maybe I don't get out much though, so the only place I see things is when I look on YouTube. So I don't hang out at I've got everything I need downstairs. I've got a garage under the house that's got a full gym, Pilates reformer, a treadmill, weights, the whole lot. So I basically never exercise in public, so I don't know what people are doing. So I think in terms of now, I'd be pretty confident because I've looked into injury a fair bit, into the relationship between biomechanics and injury risk, and into injury prevention strategies and what causes injuries in gyms in particular. In fact, I just did some research in the last couple of weeks. And I'd be pretty confident, like I would bet money, that there's not any research showing that a particular exercise, like pulling the lat pull down with bar behind your head, for example, carries any particular injury risk. Like when they do studies like that look at injury risk, they look at like gym versus yoga, so they don't look at this one particular gym exercise or that one particular yoga pose. People don't do studies on that. So I would bet quite a bit of money that there's not any research showing that particular exercise leads to more injuries. I think the rationale for that one, and I'm only guessing, but I think the rationale is like, well, when you bend your neck forward and then you load your shoulder girdle a lot, that might be bad for your neck. And that kind of seems to me like the Pilates Elephants podcast episode that we did that's got the most ever downloads, which was surprised the heck out of Chloe and me, was the headrest up or headrest down episode. And we just thought that was such a boring topic. But it seems like the internet exploded when we asked, should the headrest be up or down when you're doing a rollover or a, shoulder bridge or a short spine or something with, basically an inverted position on the reformer. And I did a bunch of research on what the risks were and couldn't find anything that suggested that it's more dangerous than any other position. So I would, based on that, I would say that this, pull down behind the head is, I can't see any reason why it would be more dangerous than anything. I can see that if you had, say, shoulder pain, like some people have shoulder pain where, this position feels vulnerable or painful or whatever. Well, with your head forward, you have to pull the bar back more to get behind your head. So I can see why if someone had shoulder pain, that could aggravate their shoulder pain. And I can see why if someone had neck pain, that might aggravate their neck pain. It might be an uncomfortable position for some people, in which case I would say, well, if you don't mind putting up with the discomfort, keep doing it. And if you do mind putting up with the discomfort, let's find a different way for you to do that exercise or some different exercise that works the same muscles. But yeah, I just can't think of any plausible, reason why that would be problematic for people. Yeah, what do you guys think? Hey, Terry, nice to have you with us. I mean, we could talk like in depth about what goes on inside the shoulder in that position if you want, because you mentioned, Andrea, shearing on the tendons, Would you like to talk about what's happening in the tendons?
I would, but I don't know about the others.
Inika, it looks to me like your house is not in daylight. Are you somewhere in the world where it's not daytime?
We have got so much rain. We're on the Gold Coast and we've just got a big front coming through. So I've been running around trying to put some light somewhere. It's dark outside and it's 11 o'clock in the morning.
Are you in, Europe or something where it's, nighttime?
Originally, but no, definitely live in Australia.
Okay.
Is it still dark? I just turned more lights on.
It's 11:20 in the morning where I am. So it's the same. If you're in Queensland, it's the same. No, it doesn't look dark. It just looks like it's not natural light, to my eye anyway. What do I know? All right. So,
daylight.
I believe you. You're not in Dublin.
No, I'm not in Dublin. No, I'd like to be.
So the shoulder consists of the scapula, the clavicle, the collarbone, and the humerus, the arm bone. And so the shoulder joint is the joint between the arm bone and the scapula. Okay. Your humerus, the humeral head, is like a ball shape, as you can see, and this end of the scapula here has kind of a socket shape on it. It's kind of hard to see on this camera, but also just because it's a really shallow socket. It's really tiny. It's like it's not even the same size as the humeral head. It's much smaller. And then over the top of the ball and socket there is this roof of bone, and that is called the acromion. And And the acromion, as you can see, is a continuation of a bone that goes all the way right across the back of the scapula. And if you put your hand over your own shoulder, and you'll be able to feel that ridge of bone, okay? And that is called the scapular spine. And spine just means ridge of, in this case, ridge of bone. You've got a few different spines on your body. You've got an iliac spine in your hip and spinous processes in your back and stuff. And so spine just means ridge of bone. And so the scapular spine, if you feel the scapular spine and then walk your fingers out laterally out to the outside, you'll find that your fingers end up directly above your shoulder joint. And that the scapular spine, you can feel it. You walk your fingers out to here on top of the acromion. So that is directly above your shoulder joint. And that is the joint, the acromion joins here. If you find the acromion again, find your scapular spine, walk your fingers out, and then if you walk in and forwards a little bit, okay, you'll feel a little kind of divot, a little dip there, and then you'll feel a bump, which is the start of or the end of your collarbone, right? So that little dip is the joint between the acromion and the clavicle, the scapula and the collarbone, and that is called the acromioclavicular joint, or the AC joint. So we have that acromion there, so a joint, in order for it to join to the clavicle, because the clavicle is the only part of the whole shoulder girdle that is attached to the skeleton, to the rest of the skeleton. The scapula itself, in this plastic model, it's screwed onto the ribs, but in you and me and your clients, it's just floating free, and it's only attached by muscles. So there is no, joint between the scapula and the rib cage. So the only joint between the whole arm, scapula, clavicle, and the rib cage is this little joint here, which is the joint between the sternum and the clavicle, and it's called the sternoclavicular joint. And you can feel that in here where there's a bump, and then it goes down onto your sternum. So that's kind of what the acromion's for. Now, in this sort of hollow space above the scapular spine, there's a little kind of ditch there, okay, and or shallow depression, and the Latin name for shallow depression is fossa. So that is, and this is the spine, okay, and so this shallow depression here is called the supraspinatus fossa. Supra just means above, higher than. So this is just the shallow depression above the scapular spine. Is this all making sense so far? Thumbs up if yes. All right. So, and in that shallow depression above the scapular spine, the supraspinatus fossa, there's a muscle called supraspinatus. It gets its name from where it's located. And the supraspinatus lives in there where my finger is, and it goes from where my finger is, it goes through under the acromion and attaches to the top of the humerus here. Just like that. That's the supraspinatus. Okay, so it starts in the space above the scapular spine and then inserts, attaches to the top of the humerus there. And its job is, as you can guess, exactly right, Carly, it does abduction. If you just think about, okay, what would happen if I pull on that? Well, it's going to abduct the arm, right? It also pulls the humeral head up a little bit. Well, depending on the angle, it can pull it down as well. Let's not go into that too deep. All right, so it basically does, particularly the first kind of 15 degrees of abduction. So like from here to there, that's mainly supraspinatus. And once you get beyond there, the bigger muscle on top of it, the deltoid, takes over. So anyway, the supraspinatus job sort of, mainly does that, that movement. Plus it's with the other rotator cuff muscles, it's really important in holding the humeral head in position in that tiny, shallow little socket that you can see there. That's not even as big as it's not like an egg cup holding an egg. It's more like a golf tee with a golf ball on it. It doesn't surround the humeral head. So the humeral head, the ball in the ball and socket, is mainly sort of held in place by muscles, the rotator cuff in particular. Okay, so there's your supraspinatus. Then you have, infraspinatus and a bunch of muscles around there that are part of the rotator cuff. So that's all good and that's all great. But when you raise your arm up, what can happen, and this is a theory that has been around for 20 years or so, or maybe even longer, 1970s, so 40 years. I need to update my dates in my mind. Is what can happen is that the humeral head, as the arm lifts up, can squish the tendon of the supraspinatus in between the acromion and the humeral head. And so, of course, when I show you this and say, oh, the muscle is here, actually the muscle is only here, right? And this bit here would just be the tendon, right? So the muscles don't cross joints. The muscle stops before each joint, and then the tendon continues to cross the joint, right? And so this bit here, even though it's the same colour in this elastic band, actually this would be the tendon here. And so as the arm comes up, the theory is that the tendon can get squished, or the high-class term is impinged, in between the humeral head and the acromion. And that is why it's thought, people get shoulder pain, when some people get shoulder pain when they lift their arm up to about here, and that's called a painful arc. So it's like, it's not painful, it's not painful, it's not painful, ouch, it's painful. And then when you get up beyond here, it's not painful anymore. So if the scapula stays still though, but if the scapula on this skeleton wasn't, bolted to the ribs, if like on a real person it's not bolted, well, as the arm comes up, the scapula, the shoulder blade, could pivot backwards without the person pivoting backwards, right? The scapula could just kind of pivot backwards on the rib cage, like so. That would get the acromion back and up and out of the way of the humerus, and so the poor old supraspinatus tendon wouldn't get impinged, or AKA squished. So does that kind of concept make sense to you guys? You're probably familiar with that concept already, right? All right, so that's basically they're called the shoulder impingement hypothesis, which explains shoulder pain. It's like, okay, when people get pain when their shoulder's like this, that's because the shoulder blade didn't get back and up and out of the way enough. The high class term is posterior tilt and upward rotation of the scapula. Okay, the scapula didn't get out of the way, so that the supraspinatus tendon got bumped / impinged between the acromion. So in this position here, if you're doing a pull down behind your head, well, that's kind of exactly the position where if your scapulae didn't get back enough, that tendon could get snibbed, under the acromion. However, and we have a whole bunch of treatments designed to solve for that. So we have a lot of sort of stuff in exercise around correcting the position of people's scapulae, teaching them to posteriorly tilt and upwardly rotate their scapulae more, so that the shoulder's not forward while the arm's going upwards, so we don't pinch it there. People also have a surgery called an acromioplasty, where can you picture the clavicle here and the acromion coming out here? Can you picture that? And you picture there's a certain amount of space in between the acromion and the humeral head. Okay, that's called the acromiohumeral distance, and just the amount of space between those two bones. Well, we have acromioplasty where they basically shave off the bottom of the acromion, right, to increase the acromiohumeral distance, to make more space there for the supraspinatus tendon. So that's an acromioplasty, and people commonly have that for shoulder impingement. And so in the last probably 3 years, there have been probably 2 or 3 very big high-quality studies come out that have really, I would say more than cast doubt, they have really kind of discredited this theory of shoulder impingement. So one study found that there is essentially no difference in the acromiohumeral distance between people who have shoulder pain and people who don't have shoulder pain. So you'd think that people who had a smaller distance there, it would be easier for them, the supraspinatus tendon, to get jammed, right? But it turns out to be that people with a small distance have no more shoulder pain than people with a large distance there. The second piece of evidence is that scapular position, doesn't predict shoulder pain. So this is a large systematic review meta-analysis that came out only last year, and found very little evidence that scapular position has anything to, is related. People with particular scapular orientation have more shoulder pain or less shoulder pain. And then a third piece of evidence, which is probably the most convincing for most researchers, is that acromioplasty, shaving off the bottom of the acromion, doesn't alleviate shoulder pain any more than placebo acromioplasty, where they basically say, okay, here you're in hospital for your acromioplasty, for your shoulder pain. They give you the mask and say, count back from 10, you go 10, 9, then you wake up. Okay. You ever had surgery and had that experience? You wake up and you're like, oh, when are you going to start? They're like, oh, no, we did it. It's tomorrow. And then you look at your shoulder and there's your neat little stitches and there's a bit of pain. There's some betadine on it and you're on a drip. All the things that happen when you're have shoulder surgery, right? But actually they didn't do the surgery. All they did was put you under, gave you a skin incision and then sewed it up and then took you to a recovery room, right? So they literally did nothing but just pretend, it's a placebo, it's a sham surgery. And so they did a big clinical trial of acromioplasty versus sham acromioplasty, and they found that both groups of patients recovered exactly the same amount. They improved exactly the same amount. So there was no difference at all in how much they improved. They both improved, right? So that people who had the sham one got better as well. And so they attributed the improvement to actually just the placebo effect of having this highly invasive, expensive, inconvenient procedure. We know that more invasive, painful, inconvenient and expensive placebos work better than cheaper, easier. Do you guys know about placebo? Yeah. So placebo research is pretty fascinating. But anyway, this was a big trial that came out in the Lancet journal a couple of years back. And really now researchers have stopped using the term shoulder impingement. Instead they call it subacromial shoulder pain, right? So it's a description of the symptoms because subacromial shoulder pain is real, but it doesn't seem like impingement is a good explanation of what causes it, right? So people still have pain, right? We haven't solved the problem. It's still a problem, but just the explanation that we thought explained it doesn't. So so we basically that's not really a diagnosis that we give people anymore is shoulder impingement, and when you have shoulder impingement, what happens is you impinge or squash the supraspinatus tendon in between the humeral head and the acromion, and so what people get as a result of that, what we thought as a result of that was, tendinopathy, right? Opathy just means something wrong. Like pathology means, disease, something wrong. So tendinopathy just literally means something wrong with the tendon. So there are many different kinds of tendinopathy, just like there are many different kinds of pathology that you can have with your body, right? So a tendinitis would be an inflammation of the tendon. That's a type of tendinopathy. You could have a tendinosis, different kinds of a tendon tear. All of those would be types of tendinopathy. And so if you've heard of people having, rotator cuff tears, that's what they're talking about, is that, the tendon of supraspinatus generally, frays or tears, tendinitis, tendinosis, stuff like that. And so those things are real. People do have tendinitis and tendon, tears and things like that, but apparently they're not caused by shoulder impingement. They're caused by some other thing. There might be age-related changes that are sort of occur in some people more than others. We don't really know. So shoulder pain's a real thing. Tendon inflammation's a real thing, but shoulder impingement isn't a real thing. And therefore, I wouldn't worry about that position. That was a super long explanation, wasn't it? What are your thoughts? Give me some feedback to tell me whether that made any sense to you or not. Well, if it made sense to you, give me a coherent comment on it.
It certainly made a lot of sense to me. And I'm going to use it later because I have some clients later that have some tendinopathy.
Great. It's super common. What do you do with tendinopathy is you should load the tendon as much as it can tolerate without flaring it up. If you flared it up, you loaded it too much. If you didn't flare it up, you didn't load it too much. You might have loaded it enough or you might have not loaded it enough. So the goal is to probably irritate it very slightly, but not so it's like, red and glowing. But, if it's a bit painful during and even a little bit painful after, but that settles within 24 hours, that's probably a good gauge that you're loading it enough, but not too much. If it's not painful at all, you're probably not loading it enough. And if it's like red hot and swollen for 3 days afterwards, you probably loaded it too much. Yeah.
Challenge accepted.
Yeah. How about you, Carly? What are your thoughts on all of that?
Sorry, read that. Yes, I understood it. And I don't have any comments, but I just have that question about the bursitis. Do you think doing exercise in the same way so that it hurts a little bit but doesn't take days to recover is helpful for bursitis?
What a great question. All right. So in between the supraspinatus tendon and the acromion, it's not literally tendon on bone. There's actually another structure underneath the acromion called the subacromial bursa, which is a little pad that sits under the acromion. And basically there's a bursa, B-U-R-S-A, that sits on a bone pretty much anywhere in the body a tendon goes across a bone, or even where a tendon goes across a muscle or something. Like often there's a bursa there, basically so the tendon slides without friction over that joint. And it's worth, I think, just understanding what a bursa is and how freaking clever they are. So if you think of a like one of those plastic lunch like sandwich bags, like the little sealable sandwich bags that you make yourself your Vegemite sandwich if you're in Australia, and you stick the and you zip it up. Well, those little sandwich bags, imagine one and you just put like a 1/10 of a teaspoon of water, literally a couple of drops of water in it, right? And then imagine if you could magically squish it down so that all of the air came out but the water was still in there, right? So it's just like there's two sides of the sandwich bag. Can you picture it? With it's just a teeny amount of water in between it and no air, right? And you seal it off, right? So, and now put it on a flat bench, okay? And now squish it down with something flat like a book, heavy book or something, right? Can you imagine that water in between those two layers would spread out so it's only a couple of molecules thick, right? There's this even surface of water. And so what you get is you get the sandwich bag, the two layers with water in between. And of course, then if you push that book, right, if you Velcro the bottom of the bottom part of the sandwich bag to the bench, right, or super glue it or something, right, and then Velcro or super glue the book to the top part of the sandwich bag, well, of course, you could slide the book and the two parts of the sandwich bag would slide over each other almost frictionless because of that layer of water molecules in between them, right? That layer of water molecules basically eliminates friction. And so that's what happens where you have a tendon that slides over a bone or over some other part of your body, is you have a bursa that basically the tendon's glued to one part of the bursa and the bone's glued to the other part of the bursa, and there's some water inside the bursa, and they just slide over each other almost completely without friction, which means that you don't rub your tendons on stuff and get them inflamed or itised. Itis just means inflammation, right? So tendinitis is inflammation of the tendon and bursitis is inflammation of the bursa. So can you make that picture? You've made those pictures in your mind. You can picture what that's all about. All right, and so we have the subacromial bursa, which is just your glad sandwich bag sitting under the acromion there, above the supraspinatus tendon, right? So that when the supraspinatus tendon gets pushed up under the acromion, actually it doesn't. It gets pushed up into the bursa, right? So one of the things that can happen in the diagnosis previously known as shoulder impingement, which we now call subacromial shoulder pain, is a diagnosis of bursitis, okay, or bursopathy, which is the general term, which just means something wrong with the bursa. And so we diagnose bursitis, right? So how do you know if a bursa is inflamed? Well, usually they do an ultrasound, right? So I put an ultrasound on your shoulder and they visualize, they have a screen, a little black and white screen, and it shows them, oh, there's the muscle and there's the bursa and there's the bone and whatever. And they go, oh, that bursa is a bit bigger than bursas usually are, right? Therefore, it must be inflamed. Therefore, it must be itised, right? So they can't actually, I mean, if you look at your finger and your finger's inflamed, it's not just the size, right? It's red, it's hot, it's, there's all of these different additional signs that tell you it's inflamed, not just bigger, right? Bigger is one part of it. Whereas when we're using ultrasound, we can't see if it's hot, we can't see if it's, red. All we can see is it's bigger or not bigger. And so there's a study in competitive swimmers, because you better believe like swimmers who are doing this all day, like they get a lot of shoulder issues, right? They get more shoulder issues than the average person. And one of the things that they commonly get is this, shoulder bursitis, shoulder tendonitis, tendinopathy, impingement, whatever. So what we find in these competitive swimmers is that a lot of competitive swimmers with absolutely no history of shoulder pain have enlarged bursa in their shoulders, right? In their non-painful shoulders. And when you think about it, right, and I don't know if you guys can see this that well, but I've got kind of a callus. Can you see a callus there? Right? Well, what's a callus? Do you know what a callus is? What is it?
Just a thickening of the skin from rubbing.
It's a thickening of the right. It's a thickening of the skin from rubbing. Right, you rub it on something like dig a ditch with a spade, or in my case, lift lots of weights. Okay, it rubs on something rough and hard, and your skin responds by thickening up. Right, that's not painful. In fact, it's the opposite of painful. Right, like that's the whole thing about a callus is it protects you from pain. Like if you're somebody who walks around in barefoot all the time, you have calluses on the bottom of your feet, you can walk on gravel without pain, right, or hot surfaces or whatever without pain. Whereas if you're somebody who's got no calluses on the bottom of your feet, when you walk around, you're like all over the driveway. So calluses are a thickening, okay, of just over the joint there, okay. That's actually an adaptive protective mechanism, right, that actually protects you from damage rather than being a symptom of damage. So there's a pretty, I'd say this is not settled science. It's still debated, but there's a pretty large group of shoulder researchers that believe that shoulder bursitis is more just an adaptive thickening of the bursa, right, like a callus on the inside of your shoulder, in response to load. And if you load your shoulder all the time, well, all of the bits in there are going to be bigger. The muscles are going to be bigger. The tendons are going to be bigger. The radius bone, from the forearm of competitive tennis players is bigger in their dominant arm compared to their non-dominant arm. It's thicker and more dense, right? That's just because we load it more, right? So all parts of your body, grow in, thicken in response to load. And so there's one school of thought that says that bursitis in chronic shoulder pain is not necessarily related to the pain as a cause of the pain. It might actually be an adaptive response that's protecting the shoulder. Whereas in the same cohort of swimmers, what they found was that people who had acute pain, so like very recent onset pain, and who also had enlarged bursa in their shoulder, they were much more common to have enlarged bursa than people who didn't have recent onset pain. So they found that in people, so basically if someone's like, oh yeah, I've just got this shoulder pain that started yesterday sort of thing, and then they do an ultrasound and the bursa's bigger, it's like, oh, well that possibly is an inflammation of the bursa, and it possibly is contributing to shoulder pain. Whereas if someone is like, oh, no, I've just had this shoulder pain on and off for 6 months, and then we do an ultrasound and find an enlarged bursa, well, that's probably unrelated to the shoulder pain. It's probably just an adaptive, thickening of the bursa. So I would say if someone's got ongoing shoulder pain, like more than 3 months, the bursitis is probably neither here nor there to it. If they have recent onset shoulder pain, particularly if there was a too much too soon type episode, that precipitated the pain. So just say, imagine this: your swimmer goes off on Christmas holidays, sits by the pool drinking mojitos for 8 weeks doing no exercise. Then they come back, in February to training camp and they start doing, 50 Ks a week in the pool, So they're totally out of shape and all of a sudden they're subjecting their shoulder to this massive load and then they get shoulder pain, 3 weeks later. Well, yeah, that kind of makes sense to me that that's an inflammation, caused by too much load too soon without building it up properly. And yeah, that probably bursitis is contributing to the pain because we know that inflammation increases. Like when your finger's swollen, right, it's more sensitive to pain, right? So same with other parts of your body. So, but then the antidote to that is just like, well, don't do 50 Ks in the pool, off on your first week back from holiday. Drop your load down until your shoulder can tolerate it and then gradually build it up, So there's not any like special shoulder exercises to do for that. It's just like more of a load management situation. Whereas if someone has ongoing shoulder pain, which from kind of your body language and head nods is my guess is what you're thinking of, Carly, and they also have an enlarged bursa, well, I would basically think that's probably not relevant. And I would think about other, what else might be contributing to their shoulder pain.
He had a cortisone injection and says it helps it. And I've been just loading it till it hurts a little bit, but not too much.
Bam.
And he's like, I can't figure out yet if it's helping or not. But he's 81. Everything else is helping, so it's good.
Great. Well, cortisone injections have a really, really, and don't say this to your client, but they have a pretty negligible effect. They have a small, transient, short-term benefit. For most people, so they give you a slight improvement in over 2 to 4 weeks, okay, and then after 4 to 6 weeks, it's back to baseline again for most people with cortisone injections. But the reason I say don't say anything to him is because there's a placebo component, right? If he thinks they did some kind of magic, medicine to his shoulder, that's going to cause some kind of benefit. So don't go and bursting his bubble and saying, "Oh, that was a bunch of crap and won't help you," because you might make his shoulder pain worse. So all those cortisone injections, they're magic. That's awesome. I expect you're feeling a lot better now. And yeah, so shoulder pain can be caused by a complex, range of things, and we don't really know. The short answer is we don't really know what causes shoulder pain. I mean, there are obvious cases where someone dislocates their shoulder or something, and that, those aside, the garden variety shoulder pain where someone goes, "Ouch, my shoulder hurts," and you're like, "Did you fall and land on your shoulder or something?" They're like, "No, I just woke up one day and it was sore," Like that's most people with their shoulder pain. Or just gradually, as I was doing a particular activity over weeks and months, every time I did that activity, it hurt a bit more or whatever. And you're like, "Are you doing a lot more than you normally do?" "No, just doing the same thing I've been doing for decades. Now it's just started hurting for no apparent reason." So that's kind of the normal run of how shoulder pain presents. Despite decades of research and hundreds of research papers, we're really not much the wiser on what causes it, although we have crossed off shoulder impingement off the list. Yeah. We do know a few things about shoulder pain, that, what helps it is psychological factors predict outcome more than clinical factors. So the biggest predictor of successful outcome in shoulder pain is a belief that they'll have a successful outcome, right? So and there's a couple of large, like 1,000-person trials that have found this. Like basically they get all the people in with shoulder pain, they test their strength, range of motion, pain, MRI, all of that stuff, and they find that all of those things have pretty minimal relationship to their outcome 12 months later, although highly disabling pain or more intense or severe pain at baseline, it predicts a worse outcome. But actually, even more than that, the biggest thing that predicts outcome is their expectation of outcome. So if they think they're going to get better or worse, they probably are. Yeah. So, and that doesn't necessarily say that we can influence their outcome by changing their belief, because it might be that they're just accurately sensing whether they're going to get better or not, right? So it might not be that their belief causes the outcome. It might just be that, like, oh no, that something feels really wrong in there and I don't think I'm going to get better, and maybe they happen to be correct about that. But it doesn't say that that's not the case. So it might be the case that when you expect to get better, right, or if you expect that going to physio and getting your cortisone injection and doing your home exercises is going to help, well, you're much more likely to do those things. Whereas if you think, well, I'm not going to get better, what's the point? You're much less likely to do those things that are going to help, and so therefore possibly much less likely to get better, right? So who knows what's the chicken and what's the egg? But we do. I can say with a high degree of confidence that doing shoulder exercises is not going to make his outcomes any worse. And even if his pain doesn't get better, he'll still have pain, but he'll be stronger. So it's like, oh, well, that's better than still having pain and not being stronger. And it may well help his pain. He may well, get back to full function. And at the very least, like when he comes in to see you, he gets a social interaction, maybe have a cup of tea and a biscuit afterwards. Maybe he hangs around with other clients and gets to chat with them in the waiting room, or, like that. For a lot of people, and I don't know about this person in particular, obviously, but for a lot of people, like especially in COVID, like that might be his only social engagement for the week, right? It might be the only time he gets out of his own head. So I think there are a huge number of benefits to exercise, even if it doesn't fix his shoulder, which it might. Yeah, but you're doing the right thing. It's like load it up as much as you can tolerate, and if it's still sore 2 days later, you've loaded it too much. Again, long explanation for basically saying, yeah, that's right. But I wouldn't worry about the diagnosis of bursitis unless there was a too much too soon type situation, like just started a new gym program, moved house and lifting a lot of boxes, something like that, which doesn't sound like he's got. Yeah. So we're pretty much out of time. Thanks for your awesome questions, and thanks for putting up with that super long and detailed walk through the shoulder. Yeah, thanks very much.
Thank you, Rab. Thanks a lot.
Thanks.
Rab. It was awesome.
See you in a week. Bye.